Welcome, everybody. Happy Occupational Therapy Week, most important week in the calendar for us as a profession. And my name is Karin Orman. I'm Director of Practice and Innovation, and I've got the honour of facilitating this panel discussion today. So, this is, as I've just said, Occupational Therapy Week, as you know, and it's also the start of our new campaign, Right Support, Right Time, Unlocking the Power of OT. So whether you're a long-standing RCOT member or you're joining us for the first time, thank you for being here. This campaign is for the occupational therapy community across all settings and sectors. And we're launching this campaign because the system, as you all know, is under pressure. But occupational therapy is very much part of the solution. We want to work together to shift the focus from crisis-driven care to prevention. That means helping people earlier, easing pressure across services, and showing how occupational therapy can lead the way. We know that occupational therapy helps people stay well for longer and avoid crisis, especially when we're involved earlier, as we bring a unique person-centered set of skills and expertise that makes the biggest impact when used in the right way at the right time, whether that's in schools, GP surgeries, workplaces, hospitals. We're already making a difference, and this campaign shines a light on the changes we're already making and the impact, but also what we can do more of with the right support and recognition. This isn't just a campaign, it's a call to action. We need occupational therapists to lead the change, whether it's in your teams, your services, or across your communities. And leadership isn't just about job titles, it's about confidence, visibility, and influence. It's about showing what OT can do and making sure we're part of the decisions that shape the future. So I'm delighted to be joined today by leading occupational therapists from across the UK who are going to share their experience and wisdom with us. We have Caroline Haig, MBE, who was previously a principal OT, but is now the Deputy Director of Nursing and AHPs within all-age personalised commissioning at NHS Devon ICB. Caroline is in early days of her new job, early hours, I should say, in her new job, and she's having some IT issues, but will be joining us shortly. Then we've got Amanda Atkinson, Head of Occupational Therapy for Babies, Children and Young People at Swansea Bay University Health Board in Wales, and Dr. Charlie Chung, Lothian AHP stroke strategic lead, consultant occupational therapist, and long COVID clinical pathway lead, and of course, previous Elizabeth Casson speaker. We had hoped to have Jane Mitchell, Condition Management Programme Coordinator from Northern Ireland, but I'm afraid she won't be able to join us today. So we've just got the three panelists, but hopefully that will give more time for us to take questions from you, the audience. So let's move to the panel discussion, but let me start with defining leadership. So we've all got a shared understanding of what we mean. It often gets confused in people's minds with management. Dictionary definitions describe leadership as selling a vision for people to buy into, to coalesce around. And we do this as occupational therapists on a daily basis. Whether we're joining a new team, turning up at someone's bedside or home, we have to sell a vision of what the profession can do to support people to improve their health and quality of life. And at our RCOT, we have a vision to achieve by 2035, and that vision is for an expanded workforce positioned to have maximum impact in improving people's health and well-being. So my first question to our panelists is, what is your vision for occupational therapy from 2035 and beyond? And I'm going to go to you first, Charlie.
Thank you very much, Karen. Happy Occupational Therapy Week, everyone. Just delighted to be here today in this panel discussion and so glad that so many people can join us. It's a big question, isn't it? 10 years, a 10-year strategy. And it seems a very big challenge to think so far ahead. But at the same time, and it's perhaps similar to those of us who've been in the profession for a good number of years, the last 10 years has passed incredibly quickly. And we face phrases such as, oh, nothing changes, it's really difficult, pressures are mounting, as Karen had said in her introduction. So the realist and the cynic, can almost say, well, okay, we can have a vision, but nothing's going to change in 10 years. But I think it's important to move forward and have a vision, and but also look at how that is implemented as part of the vision. So in answering the question, one of the key broad visions that I have, which aligns pretty much with the Royal College's workforce strategy, is the importance of occupation being recognised as central within culture, within society. We will see many instances of occupation being wrapped up in different formats. We see other professions taking forward initiatives which are about meaningful activities. I think on TV or breakfast TV a few weeks ago, there was an instance of a GP practice having a garden as part of their service. And occupational therapy was not mentioned in that at all. It looked like a fresh, innovative uh, a project which occupational therapy have been doing for decades, if not the past century, with that type of remit. So my vision certainly is to have occupation as part of the language, in the same way as psychologists synonymous with with psychologists, and physical rehabilitation is synonymous with physiotherapy. I was about to say physical therapy there, being back in the US, but physiotherapy, occupation, occupational therapy, meaningful activity. Coming on to prevention, yes, prevention I think is key, but we need to be careful with for our vision and my vision to actually go in a little bit more depth about what provision means, and that is prevention being about, yes, not developing conditions in the first place, health and well-being, maintaining a life which has full engagement in occupations, but at the same time, being a realist, we're not going to stop people fully from going into crisis and ending up in hospital. So, what does prevention mean there? What is the forward planning for an occupational therapist who's in acute services and just managing the crisis at that time? How far forward thinking can we be? So, the vision there is that we have the the recognized centrality, being central to the delivery of prevention, whether it's in the crisis mode, whether it's to the public, and whether it's to do with prevention of reoccurrence or exacerbation of current situations. So it's prevention, I believe, as part of my vision across all three parts of that. But again, getting back to the realist and uh, the elements where, okay, you can think you can have a vision, but are things going to change? And I believe they can, and I believe that certainly other aspects, more implementable aspects of the vision which I have, are one, the policy, the engagement with government, that in 10 years' time we will have routine engagement with government policies across our four nations. In Scotland, the experience is reasonably positive in that it doesn't. There's not many layers between those working in services, being at parliamentary events and having conversations with elected members, members of Scottish Parliament. But to have this as a routine part of the work we do, I think is essential for us to again be placed central, the recognition of occupation. Procedures for implementing evidence in research. A couple of decades ago, had phrases such as research is everybody's business and everybody should be involved in it. It holds true to a certain extent for me, but our vision is that research needs to be done well. And as a result, for those people who are under pressure in their services, it is not possible to do the research to the standard that we need to do research to. Therefore, any vision has the routine collaborations with our universities and with our researchers and with quality improvement as well. And service is not just all about research either, but certainly collaborations within universities, which will be set pathways, people entering into clinical academic posts, having academic homes, having clinical homes. And probably the last bit of it is that of the vision that I would like to suggest is that community peer-supported communities. And it's something with one of the other questions that may get the opportunity to speak more about, but communities having ownership of the initiatives about prevention. Also, not just about prevention, but also about rehabilitation and ongoing development of engagement in occupation. But for these communities not to be separate from statutory services, but where there's a co-creation and a co-running, but with the ownership within the community and really harnessing the power of peer support. I
Oh,
think
Charlie, I'm nodding like the Churchill dog on an advert. I couldn't agree more with the points that you've made, and I think you're absolutely right. We've got to hold the hope. We often do that for the patients, for the people we work with when they're feeling quite sort of low and despair. We've got to hold that hope as a profession, and there is a real opportunity with this growing awareness in the public around the importance of occupation, but there's a huge risk that other people are stepping into that space. So we really do have to, amplify and shout about our expertise and make sure that we are, capturing occupation as part of our practice. I think in the past we've done that on the quiet, haven't we? But we've really got to be able to amplify that. And
Absolutely.
your point about the different levels of prevention, every occupational therapist I speak to about prevention, whether it's working in A&E, whether it's in primary care, they are doing prevention. They recognize that that their focus is prevention. But how do we capture that? How do we amplify it? How do we get that across to decision makers? And I hope part of the campaign will be that discussion, and members can join us on our COT communities to after the panel discussion continue sharing their thoughts and thinking and the work that they're doing. So fantastic start, Charlie. Thank you. Amanda, I'm going to go to you because Caroline is still trying to join us. Amanda, you're on mute.
Sorry about that, all. Hi, welcome, and thank you for joining today. And yeah, it was just a bit of a nodding dog as well, Karen, there to most of the things that Charlie was saying. Yeah, and I think for those of us who are looking over, have been in the profession for a while, and those of us that are new, if we're thinking about, something hasn't changed and we want to make changes, I would just say my biggest thing today would be to go make the changes. We can make those changes. There's no part in sitting back and looking at barriers. And I would say that the biggest challenge for us really is to go knock down those barriers. We are the problem solvers. That is our unique skill set as occupational therapists, is to be creative and to make change. And so why not make those changes? And those changes can be small and they can have a big impact. But to make that change to more of a preventative rather than a crisis-driven model, I think is essential, really. I think accessibility, would be my vision, to make us really accessible. So working in the communities, alongside the communities, really collaborating. Also being more visible. And I think working in the communities will allow us to be more visible, and we can discuss that a little bit more of some practical things that we have done within Swansea Bay to enable that, really. And also making sure that we're working with our public health colleagues so that we are working with those with the biggest need and the greatest need. And again, that crisis-driven model doesn't allow for that, but that preventative model does. And being truly person-centered and not criteria-driven. That's where I would really like us to go. And being really bold and confident clinical decision makers. And I think that in order to move to that more preventative approach, I think we really need to be bold with our clinical decision making. And also, one point I think which is really important is just to have a strong, static and happy, passionate workforce, because we can't work as OTs without having that passion, that commitment to our profession, and having that sort of teamwork, really.
Thank you. Amanda, and again, I totally recognise what you're saying. I just think my favourite expression at the moment is RAC. We've got to recognise when we're being innovative, when we're making change. We've got to recognise when we're delivering on prevention. We've got to amplify that, and we've got to capture it. And I think so much of what we do is buried or hidden because we're in multidisciplinary services. We're feeding into electronic systems that don't necessarily let us pull this out. But I think you're right. I think if we feel our strength is being person-centered and problem solving, let's think about how we amplify that and get that across to
Yeah.
decision makers so that they really are supporting us to be positioned to be more effective in communities. I am delighted Caroline Haig is with us, and I recognise, Caroline, you're on your phone and you're probably feeling a little bit flustered because it's been last minute challenges. But I wondered if you're happy to talk about what your vision is for the profession. And Caroline, you're on mute, just to say that.
Thank you. Thanks so much. So great to be here. Sorry about the delay. I've started a new job today, so the IT was a little bit glitchy. So apologies for that. So my vision. So I think my vision in this space is, being shaped by the NHS 10-year plan, by our RCOT workforce strategy and our lens and focus around sort of early intervention prevention. And so I would really like to see that we are no longer primarily reacting to crisis and decline, and that we're really deeply embedded in working upstream in our neighbourhood teams. And so I always talk about upstream, so even further upstream. And I think my colleague earlier was talking about working alongside public health and thinking about really getting into the health promotion space. But I think also bringing our knowledge and skills wherever we're working now closer to where people are living their lives sooner, ultimately. And we see so many examples of that, whether that's in primary care, whether it's in working in our community teams, mental health, physical health, rehabilitation. And so actually what we're doing is building on things that we are already really got strong foundations in. And sometimes I think we might be guilty of thinking that, we're just getting on with what we're doing, and that other people won't necessarily be interested. No, that's not true. We have so much more impact and credibility in what we do, and we need to jump up and shout about that a lot more. And so I think when we're further upstream, I think we need to be enabled by data. So that will obviously be AI, or there's some amazing work going on around preventative modelling, so that we can, I know in Somerset there's OTs that have been leading the way there. So real opportunity to use the data and information that we already have available to us to target and support people when they're going to need the support they need much further ahead. So I think, and also using population health data. So when I first came across population health data, it was like a light bulb moment for me. Information that tells me what the needs are of our population, and then using that information to really think about how we deliver current services, and how we and then how we think about what various populations need, and how we change up our approach to meet that need, rather than just sort of doing things in the same way that we've always done. So there's real opportunities there. I'm also a huge advocate for technology. So obviously the significant shift from analog to digital has got huge amounts of opportunity for us. Again, we as OTs are trailblazing across the country, work in the technology space. And my colleague in Peterborough Council with her Ask Geraldine app, which is AI generative and making a huge difference to help people find solutions around technology. But I think technology enabled care, thinking about more of a hybrid. So I think we'll have more hybrid packages of care and support for people enabled by technology, much more wearable devices, as well as apps and things like that. So and we'll be booking our appointments online, using apps, and hopefully that will help to save us a lot of time. So I think really working with people before the tipping point into sort of highly dependent services. And I guess in 2035, I would really like us to not be having to explain to people about what OTs do, because I'm quite frankly bored of that. I want to be talking to people and having confident conversations with commissioners, senior leaders, members of the public around the impact OT has in the area or speciality that I work within. And I think that is so important. I don't ask a medic, what their model is or their foundation. I don't spend my time. I talk about where are you working, what you're doing, what difference you're making to people's lives, and we need to do the same. And we need to give ourselves credit, I think, for the brilliant work we're already doing. And actually not assume others are doing it. So very often we can be carrying on doing our thing and thinking, well, everyone must be doing this across the country, whereas actually you could be doing really innovative work. And that's the real importance, to be able to talk about, share what we're doing, because when we talk about and share things and we come together, we actually can deliver things at a much greater pace, and achieve, our goals around better services and outcomes for people across the country. And I guess one other thing is, I'd really like to see that we're recognised for the contribution that we can make to economic growth, whether we're supporting people to be as independent as possible, we're helping people to employment, we're helping people to carry out their everyday roles that they're carrying out. And I think we already, the optimising care work that we do, and so many other things where we are actually able to contribute towards economic growth. And I think it's important to think about that. And one last thing is just thinking about our workforce. So I think you're predicting maybe a 4% increase in our OT workforce during that time. And so that's quite a conservative amount. I'd like to see even more. But I think actually what's going to be really important is that by this point we have really clear, robust career pathways in various different sort of specialisms OTs work, and we're supporting OTs to have the balance that they need to do their best work, and that we've created the inclusive environment which helps people to do their best work, because we know when people are happy in their work, they're more innovative and forward thinking, and when they're more forward thinking and are happier in their work, they deliver better outcomes for people. And I think that's what I'm hoping for in 10 years' time.
Brilliant. Thank you, Caroline. And I feel like part of me doesn't want to go into the next questions because I think there's so much to unpack from what the three of you have just said. And I again, sort of nodding away here, I just think that we've just celebrated up in Scotland Margaret Fulton becoming the first occupational therapist to qualify. We've been around for 100 years. We should stop explaining what we do and feeling that we have to justify our existence. We are well established. It is not early days for the profession, and we've got to feel confident about that. So I agree. I'm bored of that conversation of sort of feeling that we've got to explain. AI is here. It's rapidly advancing. Again, it's one of those things that we've got to get in front of. We talk about in the workforce strategy that it's occupational therapists will use it to augment their practice. So it won't take over what we do, but we need to be confident, develop our expertise so that we can help shape it so it is safe and it is of benefit to people, to enable them with their quality of life. And your point about population health, it takes 5 minutes for you to get onto a search engine and to get figures about your local population. And I think all members can go away, all occupational therapists can go away and just go, does what I know about my local population reflect the caseload that I'm working with? Because if it doesn't, then we've got to think about how do we reach those people with high socioeconomic health inequalities, those needs. So yeah, absolutely. But I have to go on. The format is that I have to go on to the next question. So I think Caroline, you've touched on the fact that there are government policies on prevention focused delivery, but we know that funding and much of current practice is very acute, it's reactive, it's crisis driven. So my next question, I'm going to give you a break, Caroline, and then bring you in, but I'm going to go on to Amanda. So my question is, what is it that, you know, despite the challenges about the fact that, you know, money and attention goes into the reactive acute care, how are you leading on this change towards prevention?
Thanks, Karen. Yeah, this is a question which I think we've been asked multiple times, and thinking about government policies, and I think it's really important for us to understand them. And I think now is the time for OTs. If you're looking at the policies that are across all 4 of our nations, you know, they really do underpin that early intervention preventative approach. So I think government policy underpins what my service and other services across Wales deliver, shaping our principles and guiding our true intentions and enabling future growth for our services. I think that, you know, policy currently is an enabler for us to change. And to change, for me, there's a number of points I think are probably the most poignant. And the first one I'll come to for leadership, saying that bold and sort of strong leadership, and leadership on all levels, not just sort of heads of service and principal OTs, but on all levels. You know, so our OT techs and our support assistants, and leadership on that level is as important as getting buy-in and that support from senior leadership to allow us and us to feel confident to then go ahead with our bold leadership, and then to work really hard across boundaries and across professions to have that mutual respect and support and to gain that followership. I mentioned before about being sort of crisis driven, and this makes I was speaking to some of the therapists within my team around this, and they were saying how hard it is to have that unpredictable workload. And it's really challenging for both staff and service users. So really thinking about that sort of value-based healthcare approach and thinking what is the value of what we do, and where is the value of what we do? What is the biggest impact? Are we providing our services in the right way? Are we supporting the population needs where they need to be supported? So going back to exactly what the 3 of us were saying in the earlier question, Karen, is looking at that population health and where do we need to be, making sure that we are preventing those health inequalities, supporting the right people at that right time, really. So again, I think how do we do this? I think it's about engaging and connecting with service users. It's about not just saying, oh, we're working in the community, but truly embedding occupational therapy in the community, you know, connecting with others. I think that connection is really important. And I think it helps us then to manage expectations. You know, I work from children's services, and this thing about managing expectations comes up time and time again when we're talking to families. And understanding the need, promoting what we do, exactly what Caroline was saying, is essential. But, you know, so it's our job really for others to understand what we do, to show the worth in what we do, to show the impact, and so that we are managing those expectations. And also to be fluid with our approach. I think I've been asked time and time again about service redesign. And I always go back with, it isn't service redesign. You can't just redesign the service. The service has to be continually redesigning, reevaluating, to change our response, to change that ever-changing population need of our local population, because things change. 3 months' time, there will be different needs to what there are now. You know, society is changing, as we know. Economic crises are changing. The need for OT is changing. So we need to be really, really, really fluid. You know, it's never that linear model. It's constantly sort of evolving. Yeah, so I mentioned about working across boundaries. I think, you know, that I think there is no extra money within the NHS, which is where I currently work. So it's thinking about those community assets. What is out there? You know, what amazing things are already out there for us to engage with, and also to use and to support our service delivery to make it more sustainable. So working with third sector organisations, for example, at the minute, I know there's work within children's service across Wales. We're working in carer centres, we're working with childminders, we're embedding that occupational therapy approaches in the community. So we're not just, we're embedding the knowledge, and we're making the communities more confident, more resilient, and that accessibility and that reduction of those barriers, that no wrong door approach, which is what the Children's Commissioner advocates in Wales, is really, really important to allow more sustainable service deliveries. And I just mentioned again around going back to our person-centred care and the occupation base, which is really, really important. And this comes down, I think, to thinking about the needs and the occupations within our service users. And also, I come back time and time again about the team and about us as professionals, and about empowering us to be creative, being bold, and really enjoying what we do, which then keeps us a much more motivational and static workforce. Could probably talk all day on this, Karen, so I might give somebody else a chance.
Yeah, no, that's fantastic, Amanda. And you know, I'm scribbling away notes, but I really like your point about service redesign. It should be evolution. It should be fluid. It shouldn't be static. I think that's really true. But also your point, which Charlie sort of mentioned in his opening remarks about, we've got to work across boundaries. We you know, I like the idea of the community assets. I know in social care they talk about strengths-based approach. We do that when we work with individuals and families, don't we? We look at what works well, what can we build on those foundations, and we've got to take that thinking when we consider evolving our services, particularly when we're in communities. So what can we do to remove those barriers, build on those assets? I think that's a really strong point. But absolutely, if we as a workforce are feeling that we are using our expertise and making a difference, that will allow us to feel valued. It gives us motivation, and we're able then to be more creative. So thank you. Caroline, I've given you a brief breather. I'm going to go to you and then to Charlie.
Thank you. Yeah, I'm agreeing with all of that, and actually some of this might be a little bit similar, but at least we're on the same page. So I'm thinking we need to strike while the iron's hot, and that's a lot of the work that we've been doing at the moment in adult social care, and particularly, you know, for occupational therapists and working with principal OTs, is we are using the policy, the legislations, the frameworks, everything that sort of speaks to what occupational therapists is all about. So whether that's the NHS plan, whether that's CQC, thinking about what good looks like in an organisation and how OT contribute towards that, there's been a real opportunity there for us. And the fact that we have a new government, we can, you know, have a new conversation and talk about occupational therapy in spaces that perhaps haven't been talked about before. And in local authority we have the Care Act, and so really, you know, we've been, as sort of principal OTs across the country, we've been helping people understand how occupational therapy can deliver on the Care Act duties, and we've been doing that together through our principal OT network. And what has felt really important is we haven't always been in the right spaces to influence that. So actually we've quite heavily sort of focused on developing our principal OTs, who are sort of our most senior OTs in a local authority, and also our future and aspiring principal OTs as well. Because what I think is, it's all very well sort of saying we can deliver, we can support on early intervention and prevention, but if we haven't supported our leaders to be ready to deliver that, then actually it's not going to meet and sort of achieve sort of the best outcomes, really. So I think, yeah, using policies and what's current. I always think timing is so important when you are trying to land things. And I can remember, you know, I've been in so many meetings over the year, and I really wanted to get something over the line, and it just hasn't been the right time because it hasn't been the priorities of the senior manager. And actually what I've kind of help myself with that over the years is actually to say it's okay if you're doing a piece of work and you might put it on the shelf for a minute, but waiting for the right time for it to come out, you can bring that back again. And so I just think today, you know, we're thinking about striking while the iron's hot, thinking about early intervention and prevention, and it really does feel like our right time from that perspective. So we've been by bringing all of the, you know, the principal OTs together, we have created a larger voice. So we are now a collective, and we are working together. And I think that has been really crucial, because there's always been fantastic work happening in local authorities before we created a network. But actually, when you bring everything together, and you hear what everyone's doing, and then you know, we've sort of published various documents and publications, which has helped people understand the impact that we're having, whether that's improved outcomes for people, whether that's being delivering more cost-effective services and stuff. So that's sort of been really important for us. And we've also taken the opportunity to set the standards. So a couple of years ago, the standards that we expect for our OTs and local authorities. So we worked with the local government association to develop employer standards. So there are already employer standards for social workers, but not so for OT. And so that really is sort of saying, actually, we need to be able to support the workforce to have the knowledge and skills we need. So we have expectations around CPD, supervision, around workforce planning, around all of those things. And now that we have a national survey called the Health Checks, it really helps us to say, okay, we're doing okay in this in our local authorities, but actually there's real gaps here around, for example, CPD or supervision that need to be addressed. So it's sort of giving us sort of meaningful tools so that we can have conversations and get actions from it. So we spent a lot of time influencing, connecting, collaborating, and as I said, like with all of us together, it's starting to make a really big difference. And I think one of the once you understand what the pressures and issues are, you know, the most senior person you're working with. So what's the thing that's keeping them awake at night? Or what are the issues that really need to be solved? If you can understand those, you can really start to think around where the opportunities are to drop the developments and the OT related things that we want to do into conversation. So we talked about what we want to see in the future. I'd love us to continue to be the people in the space saying how we can help, rather than what about us and those kind of things. I think we really do need to shift that conversation to just understand what the pressures and how we can, and think about how we can help, but doing that in a collaborative way across sectors, with a louder, stronger voice is absolutely the way to go. And earlier I talked about, you know, the importance of workforce. We can't talk about all of these things that we're going to do without investing in our current and future workforce. And so, you know, things like the apprenticeships, I mean, across the country, you know, degree level apprenticeships has been such an important progression for us, you know, so across the country. But if I think about where I live in Devon, which is, you know, rural coastal communities, you know, people, you know, we're creating opportunities for people to learn at home, you know, whilst they're working, and in the communities, you know, that they're living and working in, which actually creates opportunity for new workforce as well. So yeah, all the time we're trying to strive to have some parity there in terms of our workforce with social workers and also with the NHS as well. So it's really important all these things are in place so that we can attract people, but also we can retain people and invest in them sort of going forward. So I think those are my main things. I guess just one other thing is just around growing the evidence base. It's always there, but actually we've had, like in local authority, we've had some, you know, some big landmark research, you know, papers that have come out, the Bath Out survey, which actually really does show the benefits of adaptations for people. The quicker they have the adaptations, the more likely they are to, you know, less likely they are to decline. So I think we need to be continuing to invest in the research and evidence base, but also back at where we're doing our jobs, don't forget to share the great work that you're doing, whether that's through case studies, whether that's through conversations around what your services deliver. Don't assume that people know, and don't assume that people are doing the same thing across the country as well. And actually, one of the things that we've done is take the next step is then, when you've collated all of these things together, to publish it in some way, whether it's a OT News or whether it's a collaboration with so for us it might be directors of adult social services and that kind of thing, so it has profile as well, and the right people are seeing it.
Thank you, Caroline, and I think you're absolutely right. I mean, Charlie talked about good quality evidence, that we need that high level academic research, but it's also that everyday evidence, and people can submit examples of service improvement on the Innovation Hub at RCOT, but we also have a template, an MS form for people to fill out, which can give us their service examples, because that also counts, that also helps in the influencing. And I have to say, over the last 5 years, the impact that the Principal OT network has had has been fantastic. It really, they've become a trusted a strategic source for at a national government level in England. So I think it's a really good example of how occupational therapists coming together and supporting each other can make a real difference. And then finally, your point about this robust business case. I think so often we hear of occupational therapists who have been knocking on doors, or they've put together a really good business case. But you're absolutely right. If it is not the immediate pressing issue that decision makers are having to deal with, it won't land. So don't feel disheartened if knocking on the door or putting a business case doesn't work the first time. Hold on to it, because there will be an opportunity. And for us at RCOT, the big opportunity for occupational therapy is around health and work. Productivity is down, the government's really struggling, there's cross-party support. This is happening, it doesn't matter if you're in Northern Ireland, Scotland, Wales or England, it is a huge issue, and it is an area where occupational therapists can really prevent people falling out of work, prevent people from struggling within work. It's in our title. We need to step into that space. So that's a window of opportunity that we're definitely taking. I'm going to now come to Charlie. Last but not least, Charlie.
Thank you very much. Really enjoying listening to the conversation. I've made a little summary of Caroline and Amanda's points, and it allows me to probably jump on to some actual, things that I'm involved in leading, to give some practical examples. To the mention of the Principal Network, that sounds really so valuable. Caroline's point about not being in the right spaces, the need to be in the right spaces. Support for leaders is a big one. I'll speak to that in a second. And the mention of case studies. The connectivity, which both Caroline and Amanda both mentioned, cross-boundary work, with a background of continually evolving environment. That is the key challenge here, I think. If I can speak about a couple of projects that I'm involved with, just to kind of illustrate some of these points, and then some professional input, and also the digital space as well, to perhaps illustrate the applications of some of these principles and addressing of some of the challenges. The first one's probably that indicated earlier on, is the hub development. It was within stroke the recognition that people will say quite frequently, it saddens me to say, that they drop off a cliff when formal services end, and is always a difficult time for people. From a professional's perspective, there is often unhelpful language such as, well, there's nothing more we can do, and that's it. They just get on with the exercises, etc. But I think as occupational therapists, we our culture has a greater in-depth understanding of the impact of occupation. Just because somebody's reached a certain stage, it doesn't mean to say they've reached their potential in terms of their engagement with occupation. So what the hubs are, and again, this kind of relates to what Caroline had mentioned in the kind of hybrid spaces as well, between digital and that in-person engagement. The hubs are hybrid to develop communities for people to peer support each other in ongoing rehabilitation, but not as a separate thing from our services, with our inputs from our services, either scheduled times or through chat online environments, or through the close to home engagements where they will take place in locations such as community centres, etc. Now, this is all in development. It's a very long-term project with collaborations with Edinburgh University, Queen Margaret University, and the concept came about from a gentleman, Simon, who doesn't mind me mentioning his name, who came up with the concept of the digital community to start with. He'd had a stroke a few years ago, and this is what he could have really benefited with, the connection with other people to encourage people's ongoing exercises and engagements in occupation, not his words, in my words, in using the occupation. So this is a wonderful collaboration. It's got its challenges in taking forward such an unwieldy project, which on major grant application, has been unsuccessful, but it doesn't stop the collaboration going forward. One of the next steps, which again touches upon the themes that have come out in this question, are collaborations with also leisure sector. And a point I want to bring out here is that often when we take projects to people, it's ticking their boxes as well. So the leisure centre are where the exercise after condition groups happen, very important, impact on both physical and cognitive aspects, as well as providing that location and community where people, it's not just about exercise, it's about coming together, it's about engaging with each other. And I know that one coordinator was doing a PhD on the other benefits of the exercise groups. So bringing all this together, and we're hoping results in a development such as Dundee Leisure have. And they were an exercise group that's become a community because so many of their volunteers are spouses, are family members, are people with the condition that work alongside the fitness instructors, work alongside some staffing from NHS. Now, what was an eye-opener here was in a recent meeting, one of the leisure centre managers had said that, yes, community runs well, but it's that injection of the NHS input that provides so much credibility for people. And it was a real eye-opener in terms of, wow, that is, we're trying to keep things at arm's length, not wanting to own it, but the actual collaboration that illustrates how important that collaboration is. And also on the tick boxes situation, we were looking to see how we could develop volunteer infrastructure and transport, at which at that last meeting, one of the leisure leads had just kind of said, well, we already have that big network of volunteers. It is already there. So on a very practical basis, the delivery of projects, because of the cross-boundary working and connectivity, as Amanda had said, really provides fruits that are ripe for the picking. Caroline had said it's the right time. It definitely is the right time to come together because so many of our organisations are working and trying to manage the challenges in the same direction. One other project dimension on the cross-boundary side of things is we have, and possibly I would suggest, and this is my opinion, that due to the medical model prevalence, that we have been siloed into working on conditions. One of my occupational therapy colleagues, Suzanne, is wonderful at always stating that if somebody doesn't have a definite label to their conditioning, they do not get an occupational therapy service. They fall between the cracks. And one aspect is the silo between mental health and physical services, where on audits of services that I was involved in managing a few years ago, in a physical older people's ward, the 3/4 of people consistently on 3 cycles of audit had a dementia or undiagnosed cognitive challenge. And yet services were waiting for each other to intervene in that space. And the Stairlift project, which some people may have heard about, which was led by the consultants from Alzheimer's Scotland, another previous Castle lecturer, Elaine Hunter, and one of the Wendy, who is one of the occupational therapy consultants as well, brought together services in Fife And there was Ailsa, who was a lead in local authority services and occupational therapy, and brought together stroke, mental health, and the local authority services to develop a system of cognitive screening to profile people's cognition, particularly executive function, in order to inform the borderline decisions of whether people were eligible for stair lifts or not. And the great thing about this is that it supported the teams in being able to say, actually, maybe not appropriate. But on the other side of things, it also gave access to people to stair lifts who previously would have been denied, probably under, discriminatory type of denial, that you have a dementia, therefore, you're not going to get a stair lift because you're going to continue to decline. So that is a project which keeps reappearing and has reappeared recently in terms of taking that forward within the service I work in now within Lothian. And then just a quick mention of the Advanced Practice Network. There are a growing number of consultant occupational therapists, a growing number of consultant allied health professions. Succession planning is an issue. And and again, what my part in this is being available to be part of the advanced practice networks and also provide professional supervision as well, so that our advanced practitioners and other leads and clinicians can come through and be exposed to the work in a similar way that managers will expose their team members to management tasks. We very much need to expose people, to occupational therapists, to the clinical academic realm, the national realm, the engagements with government type of realm, so that when consultants move on, the advanced practitioners and other lead specialists are, we can't have them unprepared to take up these spaces. And finally, the digital side of things, which I'm very interested in, and also being in the right spaces, having the right conversations. The illustration I have here is that we speak about robotics, we speak about artificial intelligence, etc. But the challenge of getting these implemented is huge. And there are some practical challenges that could be overcome by good guidance and awareness. So if I list some things, and people in this meeting may or may not be aware of some of these things, we see a device or technology at a conference, or we're approached by something. The thinking is we use that, we'll test it out. If it's useful, we'll integrate it into our practice. It doesn't work out that way. And some of the barriers are, is it CE marked as a medical device now? Because if it's not, we really shouldn't, we can't buy it. Although some boards do, because their medical physics departments kind of turn a blind eye to this. If it is CE marked, then perhaps we can get it, we can go through trial. Then do we know the indemnity procedures for that trial to take place? Then if we've gone through that, we have the data protection assessments to undertake. We have the systems IT security procedures to implement as well, and to pass these assessments to our organizations. And then that's only the beginning of the story. We begin the trial. We need to have the time for enough occupational therapists to become familiar, to implement that technology, and to embed it, and to have time to move away from their headspace of default to actually being able to implement it. So the challenges are huge there. And in the recent engagement at the Scottish Parliamentary event for the Allied Health Professions Federation, the Jackie Bailey, who is the deputy leader of the Labour Party in Scotland, she was hosting this meeting, and she was really championing rehabilitation, allied health professions, but also visits to Strathclyde University, Wishaw, which is an occupational therapy-led enhanced rehabilitation technology space, which has been visited by various people of interest, have various bits of technology. But then kind of was able to have the conversation. I'm thinking about Amanda's Bold, and I've been a member of the trustee in the Elizabeth Castron Trust for the past year now, so it's the great mantra for the profession of being bold. But approaching Jackie Bailey and just having a conversation and asking her that, did you know that some of the technology that's been on display and being demonstrated and used, actually we can't purchase because they're not CE marked as a medical device. And some of the developments that are coming through from our robotarium in Edinburgh, one company, notable company, has had to move their development abroad to the US because they can't they don't have the resources to comply with the medical products regulatory agency. So there are many things that are creating barriers both at local level and national level. So yeah, so that's my other input in trying to develop a guide for this locally, which hopefully will be useful nationally as well. I think that's probably all the key points I wanted to make, that on the back of Caroline and Amanda's points.
This is my first rodeo. I've managed to mute myself and then not unmute. So apologies, everybody. I was so keen to respond, Charlie, and just to say that RCOT has guidance as well around using AI. We've got some principles, so hopefully one of my RCOT colleagues will put that in the chat. But yes, it is a complicated. We can say we can champion, we can think about safety, but it is complex, and there are lots of barriers around it. I loved your points about cross boundaries. So often we think about working cross boundaries between NHS and social care, but actually it's thinking about all the different community assets. I'd also do a shout to independent occupational therapists who are really good at capturing what they do. There's a lot we could learn from them in statutory services because they are having to capture the impact of what they do, and they are having to sell themselves and put the business case. So they are a useful resource as well. But I think you're absolutely right. Village halls, using different gyms and social spaces out in the community is really key. And we just always talk about, as occupational therapists, we're educated in physical and mental health, but we lose it. We go into systems that don't enable us to draw on that. And we did, a couple of weeks ago, launch a new model for advanced practice for occupational therapy, which draws on social justice, moves away from the medical model, but really talks about our specialism as generalist specialists, not just particular areas, conditions and areas of practice. The reality is most people that we work with have more than one health condition. They have a complexity of needs. We've got to move away from that medical model and that condition focus. So I absolutely agree with all of your points. I'm sort of aware of time, so I'm going to move us on to the next question. And I just wonder what advice you have for the audience on how they can build their identity and experience as leaders. And Charlie, I'm going to come to you. Sorry, I haven't given you a breather, but hopefully your mic's still on and I'm going to come to you.
I've quite a short answer for this, actually. I think it's getting back to Amanda's point, being bold, yes, but actually appreciate the leadership you already have in relation to listening to others, taking points forward, understanding others, and then it probably quickly comes to a point where you want to represent a point of view, whether it's a service development, whether it's a certain way of doing things within your service, and then you are adopting a leadership role in taking that forward. And then that's where, yes, be bold in whatever vision you have for the immediate future. It might be days in the future, it might be months in the future. Take that forward, but take it forward. Don't feel it needs to be your ideas. Actually corralling the ideas and inputs and experiences of others is hugely beneficial.
Thank you, Charlie. Excellent point. Yeah, it's building, isn't it? Don't start with a blank piece of paper. Build on what's already out there. And then also for me, it's you then move as a group. It's going to be more powerful, isn't it? I'm going to come to you, Amanda, and then Caroline.
Thank you. Yeah, I suppose it's about reflecting on what leadership is, on what is your individual leadership style. And in order to be a leader, you've got to have followership. So you really need to understand the community and the team that you're working in and the space that you're working in at that time. And sometimes leadership skills need to change depending on what space that you're in. And whether, I am very, very passionate about compassionate leadership. That really runs true to me as a person, within my morals, and also that has worked for me within the space that I've worked in. But I keep coming back to the word bold, and that's I think Charlie and I, that's our word from today. Is that sometimes you just need to be you need to be bold. You need to speak up. You need to have confidence, and you need to celebrate successes. And I, as in my leadership role, I have watched and learnt, and I have learnt probably more from what I don't want to be, from other people, just as much as watching those leaders that I really am inspired by.
Thank you.
Yeah.
Thank you, Amanda. Sorry, didn't mean to cut you off. I'm going to go to Caroline, and then we're going to take questions from the floor.
Brilliant, thank you. Not just because it's RCOT that I'm promoting this, but it is. I really think it's important to invest in yourself. Don't wait for someone else to say, you're going to be a great leader. Actually, invest in yourself. And one of the good ways to start that, because I know I did it myself at key points in my leadership journey, is use the career development framework and map out where you're at, because you can really understand for yourself what your strengths are and what your areas are for development. So for me, at one point when I did it, I realised I needed to invest more in research. I then went in the MSc direction, and I hadn't thought about doing that before, but it encouraged me to consider it. It's not all about doing postgraduate study at all, but it just helps you recognise your strengths and weaknesses. I think, again, take initiative, seek out opportunities. So a lot of my biggest sort of development opportunities has been through leading small projects and that have become bigger projects over the years, and that gives you an opportunity to shine and do your thing in the way that you do things. So I think I would really look for that. Think about your influencing skills. So where are you at with your influencing skills, and have you ever thought about that? So someone once showed me an influencing styles survey or something. So you look at what's your influencing style, and actually where are the opportunities for developing in my influencing style. I'm a big fan of Cialdini's 7 Principles of Persuasion. There's a really snappy video on YouTube and called The Science of Persuasion. I'd really encourage you to look at that, because for me it is light bulb moments around the kind of things that you can do to get people on board and influence them. Again, in my little quick top tips from Practical Guide is find a mentor. Find a mentor, be a mentor. So you know more than you think. So take the opportunity to sponsor, lift other people up around you. But also, you might have already got a mentor and you don't realise it. Really utilise the mentor or find one to support and develop you in your leadership journey. And finally, I would just say be inclusive, be you. Because creating the right environment for people to thrive, being inclusive, allows people to bring their whole self to work. And like my colleagues, I'm a big fan of compassionate leadership, the importance of creating a space to listen, to understand, and importantly, take action. It really does empower people. And I feel like when I've been in teams, when I've been able to be my full self, and I have delivered my best work, and it's very empowering. And so think about what your values are, the team that you're in, and whether it aligns and where the opportunities are for you to change things up, and most importantly, be kind to yourself and everyone around you.
Thank you, Caroline. So I think you've all touched on listening, understanding, then taking action, and being bold. And I think your point, Caroline, just around, what's the motivation, what's the value, and using that to help you be bold. Because it can be scary, can't it? I keep thinking of the 1970s self-help book, Feel the Fear, but Do It Anyway. That's what we've got to do.
I almost said that, actually.
I'm not the only one with the cliche. Okay, thank you, everyone. There's just so much we can ask you, but I'm going to go to Rob's question in the chat because it's had 10 votes. So the question for all of you is, how can OT specific outcomes be used to show impact when other professions often don't understand their focus? And Charlie, I'm going to come to you first on that one.
I love the question. Great question, Rob. It's a challenge, isn't it? Simply because that sort of occupational therapy outcomes often are the result of everything. And so I always see frequently occupational therapists always say, "Oh, how can we, sort of really state our outcomes when it was the members of the whole team, that contributed to the outcome of the person?" And a response to that is we need to own our own outcomes. Sort of the result of many people that come through multi-professional services are going to have input from various different professionals and various different services. But when we look at the occupation outcomes, be it through Canadian occupational performance model, be it through more generic tools like the EQ5D, and I have an example of this, from a few years ago where EQ5D, for those of you that are not familiar with it, is just 5 points, with 5 points, and it's got things like dressing and washing, pain, anxiety, so it's generic, but there's a lovely scale on it, with 0 to 100, about what your health is today. And we had built this into digital systems in my work in Fife. And what it demonstrated was that some of these factors stand still. For some people that were coming through this frailty service, their mobility hadn't improved. The dressing had improved a bit, etc. But the profile was more important than the overall outcome, because uh, the engagement with occupational therapy had led their health to increase, because they probably felt that greater sense of control. And it meant that some parameters didn't increase, but some of the occupational therapy parameters did increase. So just to summarize that is that, yes, we work in full teams, but let's own our outcomes and report our outcomes, again, with whatever outcomes you actually use.
Yeah, and I think that's an excellent point, Charlie, that it doesn't necessarily have to be an OT specific outcome measure. Things like EQ5D really capture a lot of what we're doing in terms of supporting people's quality of life and their sense of well-being overall. So I think that's an excellent point. I'm not necessarily going to come round in it because we want to get through as many questions as possible, but Amanda or Caroline, is there anything you wanted to add to that question?
Yeah, if you don't mind, I could come in there, Karen, really. It's
Thank
just
you.
around, thinking about, it's about who are we going to influence and why are we collating the outcome? So making sure that we're getting the best and the right outcomes. For me, sometimes if we're looking at outcomes to improve commissioning services, then that's different, maybe some different outcomes to if you're evaluating and trying to do more service changes and improvements in what you do clinically. I think sometimes thinking about how the biggest influences, one practical example I will use really is going to an exec board. People were taking lots of data sets in, so then my senior leadership team then asked me for outcomes. So I sent a patient story with a patient just giving feedback. And it was such an more of emotive feedback, and that definitely was more beneficial than it would just show in a data set. So it's around, I think, is thinking why are you using the outcomes and what are we achieving? I think would be my last comment.
Yeah, and that's similar to what we were saying about the business case. What does your audience need to know? What's going to be of interest and of value to them? So actually tailoring how we present the information for that audience and thinking, what is it that you want to achieve?
Yeah.
With that set of decision makers. So I think that's an excellent point. I'm going to move on to another question. What do you think are the barriers to boosting public understanding of occupational therapy, especially with the wide variety of roles that we have within the profession? Even amongst other AHPs or even commissioners, there's often a lack of understanding. So Caroline, I'm going to bring you in on this one.
Sorry, as I'm muting. What is the lack of, what are the barriers to lack of understanding about occupational therapy? So maybe we create some of those barriers ourselves sometimes, because actually I think, you know, we've had, you know, I've been very fortunate to be awarded an MBE recently for services to occupational therapy. And I know the question is going to come from most people around what is occupational therapy. And actually, because it was for services to occupational therapy and adult social care. And actually, I found I haven't initiated, I think I might not have initiated as many conversations around what I do in occupational therapy, because I'm concerned around people, you know, I'm thinking people are going to ask me the question. But actually what I've found is the more conversations I'm having with people in everyday life, as I said earlier, talking about the impact that we have, that makes sense to people. It does make sense where we talk about, I was working with someone, we sorted out an adaptation for them. It reduced the disabling impact of the adaptation. It meant they could stay at home for longer. Everyone realizes that that is beneficial to people's lives, and we are, you know, making a positive contribution. So I think, as I was saying earlier, rather than focusing on what we do, focus on or, you know, what OT is, focus on who we are. So and think about what our own sort of dialogue is around that.
Yeah, yeah, absolutely. And there's some simple things that people can understand, such as, you know, keeping a child in school, reaching their education potential, um, supporting people to keep working. There are some easy wins, isn't there? And it doesn't matter if people don't fully understand the breadth and the range of occupational therapy. You're right.
No,
That focus on impact. Yeah,
yeah, other professions don't do the same, you know, so why do we feel like we need to do it? So
yeah, yeah, absolutely. Okay, I'm going to fit in a couple more questions. So we have a question around in acute settings. The commissioning priority is to reduce the length of stay, which we can do and we can evidence. But how can we evidence the work we do to prevent future readmissions? This work is often seen as delaying discharge and therefore viewed negatively. Charlie, I'm going to come to you and see what you have to say on this one.
Yes, I always remember the heat targets in Scotland that were about couple of decades ago. That's how old I am, and there was a measurement of getting people into hospital and length of stay, but no measurement of how many readmissions happened. And I think Stroke do this well in Scotland, the National Audit Programme, because they don't just take in length of stay. There's actually the question in the National Audit of days at home, and so that data has been reported for years now, that we can actually make use of that data to profile those people with less less length of stay at home. So a simple metric like that, does take in account the length of stay, yes, but how long were the people at home before something happened, before there was a readmission again. So I think that is key for doing a deeper dive into what the impacts of those that didn't stay at home for very long are, and also the comparison between boards, because every board area these statistics are reported, and if somebody is a bit of an outlier, either positive where there can be lessons learned, or negative where actually we need to really determine what the impact there is. And it's an opportunity for occupational therapy, because much of this is about engagement once people are at home, the preparation, but also the ongoing uh, engagement with occupation once people are home.
Okay, so I like that. So so it's flipping that around rather than the focus on length of stay in hospital, thinking about the amount of time people are the days at home. And the reality is there are certain people or certain stages of life when people are going to have hospital admissions, but it's about making sure that that isn't, the whole of their experience and that it's not
Yes.
impinging on their quality of life.
Yeah, it's about understanding that, so that we can, we said at the start about understanding population and, being able to intervene appropriately.
That's great. Thank you. I don't know, Amanda and Caroline, if either of you've got anything to say on that particular question.
I was just going to say that, again, there's a huge opportunity for us. So I think cost avoidance is really difficult to often show, and we do a lot of that. But I think given the focus on early intervention and prevention now everywhere, I think now would be a really good time to be working with our finance teams and our data teams, because it's amazing what data teams can do with the information that we input into our systems, working with them to sort of really think about what we can do to evidence that more greatly. I think there's more interest in cost avoidance than there has been right now. So there is opportunity to perhaps bring that data and information out that you had before that people didn't look at or acknowledge, and then work with a finance team or a data team to try and sort of validate that and show the benefits of the interventions you're doing. So, for example, if I was working in transitions and I had there was I was helping someone with their outcomes, so they were transitioning, from children to adults. At one given time, if I didn't have an OT working in that team, I might be able to evidence the difference in terms of outcomes the following year when I did have an OT in the team. And also perhaps we might see the budget reducing as well. But I don't get into lots of that, but I just think get your colleagues alongside you who's got this knowledge and expertise to help evidence it.
Thank you, Caroline. And I think we're going back to some of our themes around cross-boundary working, isn't it? Going and talking to the finance, going and talking to the data team, because you might not know what the answer is, and you might not have quite nailed what you're trying to find, but they can help you do that. So it's drawing on their expertise. So we've got that point about using your assets and also being bold. Go off and talk to the finance team. You might not know them, but get to know them. Amanda, you're desperate to come in.
Yeah, I was just going to say, just because excited about this, that I completely agree with Carolyn, really, that, I've just got a couple of practical examples of how that has influenced and benefited the growth of my team. I was questioned, moving from that crisis to the more preventative approach, a number of years ago, and I was asked, why on our digital clinical systems is the contacts down? So these are individualized contacts. Why are those down? So then I was able to work with the digital team and then to influence them and them to realize actually what we have done is we have benefited probably 5 times as many children, young people and families than we would have done by changing our approach. But the digital system doesn't support that. So it's really trying to influence and say that the digital systems need to support what we do as occupational therapists and not the other way around. And again, working with finance colleagues, we were able to get commissioning and service level agreements from education. So we've got quite a big team now of therapists working in mainstream schools because we were able to much more cost effective, because we are reducing the requests for support into health and treating and supporting, intervening with children and young people at the right time in the right place.
And you've done a fantastic job sort of benchmarking that across Wales as well, haven't you, Amanda? So I think, starting local and then thinking, how can you roll that out regionally and nationally?
Yes.
I think that model of working in schools is really driving things forward within children and young people's services. So, it's a fantastic piece of work. So if members don't know about it, OTs don't know about it, get curious and come and find out some more. We'll be able to, Amanda, perhaps be able to post some on RCOT communities, some links to where people can get information to that document. Okay, we're starting to run out of time, but what I would like to do before I finally wrap up is just ask each of you if there is an action you would like our audience, the participants today, to take away as part of OT Week and in part of our campaign of right time and right support. So, Amanda, you're on the call. Can I come straight to you? Is that okay? You're off mute.
Yes, of course. Thank you, Karen. It's really hard to think of one, isn't it?
I won't be strict.
Okay. Thank you. I go back to connections. I think connection is absolutely key, and that's connections with the communities to understand what our local population needs. Connections with other services. So for me, it's those connections with my education colleagues, which has been a huge influencer, and we've got fantastic outcomes for children and young people across Wales because of that. And also connection with my team. I have a really strong, closely connected team, and this has been absolutely crucial in the service changes that we're able to make. And just as you were saying, Karen, is to and then have strong connections with my colleagues across Wales. Other children and young people's OT services across Wales are doing absolutely fantastic things. So it's about sharing that knowledge. No point in reinventing the wheel. If something works, just be strength focused, and let's be bold in sharing those positive outcomes. So spreading, scaling, and connecting with others, and also connecting with our policy leads and connecting with ARCOT. I mean, Sally Payne has been fantastic with Children's Services and OT across Wales as well. So that connection across is really, 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 really important. And I would say shout loud and proud of what we do, you know, and share it. I think that's really, 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 really important. And being accessible, breaking down those barriers so that we are accessible. I really, within Children's Services, I'm very against those who sit back in secondary care, waiting for referrals to come in. Within my service, we are paperless, we are accessible, we get back to people, we speak to people, everybody when they need us. So we are there to support the right time in the right place. And we're not criteria driven. We are occupational therapists, so we are person-centered. I could go on, but I will let somebody else.
Thank you, Amanda. And I think when services are stretched, it is easy to get into protectionist mode, isn't it? And that's when you can get very fixed on your referral criteria because you feel that you're drowning. But actually, as you say, that's not necessarily the right approach to take. Caroline, I think you're eager to get in, so please join.
I completely agree with what Amanda said, and I always talk about connections. So connect. And when you've connected, build on those relationships, you know, take the time to get to know people, understand their pressures, help them understand what yours are, and then think about how you can collaborate together. And then when you're in those spaces, use your influencing skills or develop your influencing skills so that you feel more confident in those spaces, so things might go your way a bit more. So I would, I guess, as an action, really encourage you to watch the 7 Principles of Persuasion and to think about how you feel about implementing those in an ethical way in your practice.
Thank you. I'm thinking A, B, C. A, amplify what you do. B, be bold. C, connect and collaborate. So, Charlie, last word to you.
Thank you. Great points. I'd just like to say to those on this call, bring the 4 pillars together. Don't think of them as separate. Make contact with your policy officer, your RCOT policy officer. They do a brilliant job. Katie McGregor in Scotland is doing an exceptional job and is very close to the occupational therapists and taking issues forward and also communicating issues forward. Make contact with your universities and use of students as well. Students are willing to be involved in evidencing and being involved in becoming in looking at research questions. And also when you're searching for answers to challenges within your area of practice, do the searches, you know, make that just part and parcel of what you do. There's so many open access journals and now in addition to our own access of the British Journal of Occupational Therapy, but the evidence is just so accessible to inform your practice. But bring all these things together to inform your practice and your developments, both as clinician and leader.
Thank you. And I just want to say a huge thank you to all 3 of you. Today's event's just shown us what's possible when occupational therapists come together across sectors and settings and also just different stages of career to lead change. And you've just given us some very powerful examples of how OT is already shifting the system, helping people earlier, easing pressure across services. and how you are leading the way in shifting that focus from crisis to prevention. I've got all sorts of catchphrases buzzing in my head now, but I just want to reiterate that the catchphrase that we're launching today as part of the annual campaign is right support, right time, unlocking the power of occupational therapy. It belongs to all of us. Our collective leadership really matters. Every occupational therapist has a role to play in shaping the future. And when we come together, we can amplify our influence and strengthen the profession. We have got our COT communities. It's a social learning space. I think Karen Erskine asked a question about how do we support, how does our COT support members in the different areas of practice? That's the space to come together. That's the space to share ideas. That's the space to get support and to help you develop your vision so that you can really lead within your area of practice. I think, you know, we can show decision makers that occupational therapy isn't just valuable, it is absolutely essential. And we just need to feel confident and make sure that we're embedded in places where people live, work, go to school, seek support. You know, we need to be more accessible, and we can do that. And I hope that the campaign isn't just for OT Week, it's about building this momentum as a profession throughout the year. Thank you, everybody, for joining us. We couldn't answer all of your questions, but I will try and follow up on some of those within the chat on RCOT communities. I think whether you're a member or not, you are part of a movement. We want you to stay in touch, keep speaking to us. There's been some great mentions of some of my colleagues at RCOT. There are policy and public affairs leads in each nation. We've got professional advisors. You know, we've got a great team at RCOT that can work with you and support you so that we can really expand our influence. There are recordings on advanced practice that I mentioned earlier, and also how to influence, what we can do individually to influence. There's a recorded webinar. If it's not on the website, it is coming on shortly. So please look out for that to get some more information. And if you're not a member yet, just please consider joining us. Shape the future with us. And, you know, it's really important that we embed occupational therapy and make us a sustainable and growing profession, whether that's within health, education, social care, and of course, independent practice as well. So thank you, everyone, and thank you to the panelists. It's been a really engaging, interesting, and thought-provoking conversation. Goodbye.